Thank
All
you.
right, and now on the Zoom, we have Dr. Cassie Brady, who is also opposed. Dr. Brady, you're recognized. Let us know who you are and who you represent, please.
Great, thank you. I am Cassie Brady, pediatric endocrinologist at Vanderbilt Children's Hospital. I want to thank you all for your willingness to hear from healthcare and mental health care providers today regarding the medical care of transgender youth. I'm a board certified pediatrician and pediatric endocrinologist at the Monroe Carroll Jr. Children's Hospital at Vanderbilt. I'm a member and co-director of our multidisciplinary team providing care for transgender and gender diverse youth. I'm speaking today on behalf of my team and the gender diverse transgender patients that we serve. Guidelines for appropriate treatment of gender diverse youth have been developed and endorsed by the Endocrine Society, Pediatric Endocrine Society, American Academy of Pediatrics, the Pediatric and World Professional Association for Transgender Health, and the American Psychological Association, as well as other medical organizations. The teams across our state utilize these guidelines when initiating therapy to block puberty or begin gender-affirming hormones. There are safeguards at every step of the process, and decisions to begin hormones are always informed by the input of mental health providers, other expert physicians on our team, and the patient and family. Detailed informed consent is obtained from the patient and parents or guardians prior to starting any hormonal therapy, and the consent provides information about anticipated effects of treatment, potential side effects, as well as the reversibility of such treatments. While I appreciate your openness to talking with healthcare providers about this issue, I still have concerns with it. Transgender and gender diverse youth face a very difficult road. Like Ms. Wilkerson mentioned, gender diverse youth are at increased risk for suicide. Nearly half consider it, and a third actually will attempt it. And when receiving gender affirming care from all aspects of their lives, schools, homes, medical environments, suicide risk declines, and these individuals live longer, healthier lives. Thus, providing affirming medical care to these individuals saves lives. Secondly, the bill is not requested by medical professionals involved in the treatment of these patients. The care of transgender and gender diverse youth is quite complex and specific to the needs of each individual child or adolescent. We already have expert evidence-based guidelines that are updated regularly based on research. A law will not keep up with the most up-to-date research or guidelines. In addition, the use of blockers or gender-affirming hormones is not medical practice in children who have not reached Tanner stage 2 natal puberty. And so physiologically, blockers do not work unless a patient is in puberty. This is already stated in our protocols. Thank you for considering these issues and taking the time to hear from the providers delivering care to this population.
Thank you. There's questions? Senator Hensley. Senator Massey.
Thank you, Mr. Chairman. And you use the term transgender and gender diverse. Well, what does that mean? Gender
some individuals
diverse.
I'm sorry.
What does I'm sorry? No. What does that mean? You use those terms like they're different. Transgender is different than being gender diverse.
Sure. So transgender individuals, when we think about individuals, when you are born male and identify as female, that'd be a trans female. If you're born female and identify as male, you're considered trans male. There are individuals who do not fit those specific pockets necessarily in their gender identity and may be considered gender diverse or gender non-conforming, which is another term used, gender incongruent, which I believe this bill may use some of that terminology, or non-binary individuals, meaning they do not fit those specific trans male, trans female, but do not also identify with their specific sex in which they were born.
So what are the other options? If there's other options besides male and female?
Yes, that would be gender non-conforming, gender incongruent, gender diverse.
So what kind of hormones do you give that individual if they're not sure if they're male or female?
Well, they work closely with the mental health provider to identify their gender identity and work with them on working on establishing that, informing us on who they are, and And we would usually, if we talk about blockers are really helpful in this population because it helps them work with their mental health provider in determining their gender identity a little bit more fully.
So a mental health provider has to help them determine what gender they are?
No, a mental health provider helps them talk through their gender identity and helps guide them in their journey. They don't determine their gender identity for them. They usually know it, but these are children and adolescents who are describing these. And sometimes we want them to work with mental health providers rather than getting information from the social media, from the internet, etc. We want them to work with very specific, certified, trained providers in this profession.
Okay, thank you.
Senator Massey's recognized.
Thank you, Chairman. And Doctor, I just kind of to clarify just a little bit, there is the hormone blocking therapy and kind of what that does and maybe what the kind of normal age that might start at and if that's reversible. And then I think there's the next step of hormone treatment and what that kind of involves and what age is that normally started at?
Thanks. So that's a great question. And it is not age that determines how we start these. It has to be a pubertal stage. So you can enter puberty. A normal age to enter puberty in a girl would be at 8 years of age. A normal age to enter puberty in a boy would be starting at 9. So that's considered normal puberty. Anything before that would be precocious. So anybody who starts at Tanner stage 2 development based on laboratory assessment as well as physical exam would be able to be put on a blocker hormone therapy. That blocker puts a pause button on their puberty and gives them time. We use the same kind of medication in my practice and in pediatric endocrinology for those kids who have puberty prior to age 8 or 9. And so it's a medication we've used for many years. That is the completely reversible treatment. And that's not based on age, that's based on Tanner stage 2 development. We can use it in later stages of puberty as well, but they must be in puberty.
Okay, so that would be, so I mean, just kind of the average age that you would maybe be doing that. I know you can't put ages on it, but just to give us some semblance.
Sure, average age of puberty is around 12 and a half.
Okay, so that would be 12, and that would pause the button. So then the other form of hormone treatment that is, I believe, is not reversible. Is that correct? Or that is that? I think there's one stage that they say not until you're basically through puberty, or it's about age 16 is what I've read in some things. And I'm just enough to be dangerous. So if you can kind of help me through this, thank you.
Sure, absolutely. It sounds like you've been doing your reading, so that's good. So age 16, so those are the prior guidelines. The guidelines were updated in 2017. So the prior guidelines from the Endocrine Society did say that if we were going to give gender-affirming hormones, such as testosterone or estrogen, those needed to start at 16. Those guidelines were updated, though, a few years back, and they said that those could be around 13 or 14 based on compelling reasons. And the compelling reasons from an endocrinologist standpoint would be if that person's been on a blocker for a long time, they know their true gender identity, they should, in order to prevent any more mental health concerns, it would be best for them to proceed with their puberty alongside their peers at that given age. So 13, 14 makes a lot more sense than 16, which is actually considered delayed puberty. So that's someone typically on a blocker. We could have someone come to us who's never been on a blocker and might be 16 or 17, and we can get those gender-affirming hormones started because they might be all the way through puberty, and we would start those hormones. They are reversible as well, not as reversible as the pause button as that blocker. So there are certain things once you get these started that may not reverse back. So that would be something like facial hair, deepening of the voice, but that takes time. That takes a lot of time for those changes to occur that are not as reversible on the hormone therapy. Now, when we talk about the therapy that is irreversible in our guidelines, that's the surgical therapy. But even that, with extra surgery, you potentially could reverse it. I am not a surgeon, but that is the more irreversible treatment that these individuals might have.
Okay, and these patients that would be these youth that would be coming and asking for this type of the blockers or the affirming therapy, they would have their parental permission, and then a doctor would be following the standard protocols that are in place. Is that correct?
Absolutely. We require both parents to consent or guardians. We take it very seriously too. If there is one parent that is not in agreement, we have a lot of sessions with that parent, talking them through it. And if we can't get both parents in full agreement and they aren't in full agreement, the patient must wait until they're 18 years of age for that. And I see these patients quite often, about every 3 months, and I'm doing a laboratory assessment based on our guidelines. We follow very strict laboratory assessment, sometimes bone density, sometimes x-rays to see what their growth plates are doing. And it's similar testing that we would do with anybody who might be cisgender and have to have these treatments for late or early puberty, or somebody who might not actually go into puberty for other reasons. So we use these medications in our practice for other conditions, so we know what to assess and what to monitor.
Okay, thank you. Thank you, Chairman.
Thank you. Further discussion or questions? Seeing none, thank you for being with us.